We have finally made it. This is the very last of our lectures in this class. So yay, woo! And memory and cognition. I mean, cognitive neuroscience is such a cool field in general. So it's unfortunate that we're not going to be able to dive in as deep as I would have otherwise liked to. But it's okay. We're going to cover some pretty big topics in cognitive neuroscience anyways. And we've actually discussed a lot of these throughout the semester. I mean, it's kind of just a part of the way the brain works anyways, right? Learning, memory, attention, right? Things that captivate your attention, how you consolidate things into memory, right? All that stuff is like things that we discussed throughout this entire semester. But cognitive neuroscience particularly deals with those types of mechanisms in general. So here's an overview of what we're going to be discussing between today and the next time we meet, unless we're actually able to get through all of it today, which I'd be pretty surprised by, but we'll see. So we're going to go into a brief intro, like a brief overview of cognitive neuropsych or neuroscience. We're going to discuss memories, short-term versus long-term memories, declarative versus non-declarative memories. We're going to talk about memory consolidation, so involving priming, for example, conditioning, extinction, motivation, and forgetting. And then we're going to talk about, at the very end, Alzheimer's versus Lewy body dementia. Alzheimer's, mostly memory loss. Lewy body dementia is going to be both Alzheimer's plus Parkinson's disease. So you get like the worst, right? The worst of both worlds. So horrible stuff. So what is cognition and what is cognitive neuroscience? Cognition is described as the mental action or process of acquiring knowledge and understanding through thought, experience, and the senses. Literally everything we've learned throughout this entire semester. So all that comes into play when we discuss cognition. And these are the major topics that do fall underneath cognitive neuroscience. So the research into consciousness, what consciousness actually entails, right? We already discussed consciousness a little bit, right? Reticular formation is going to be one of the key components of consciousness. If you knock out the reticular formation, you render the individual unconscious, right? That's what our general anesthetic type drugs do. Cognitive process, we've discussed that pretty much throughout this entire semester. Affect and emotion, we briefly discussed that a little bit in psychiatry, but there's a lot of studies that are like specifically dealing with affect and emotional processing. Attention and perception, right? The way that we look at the world, how we perceive the world, and the things that affect our perceptions of the world. So perception is a really interesting area of study, especially when we're dealing with things like psychosis, delirium, delusions, delusional thought process especially, right? Because these are like fixed false beliefs, false altered states of perception, right? Schizophrenia also, you get altered states of perception. So it's a really cool field. I'm going to play these videos out in a second. Let's go through the rest of these. Decisions and problem solving, right? Decision and problem solving. I mean, this has a lot to do also with the basal ganglia, right? Motivation, learning, habits, all that. Effects of stress on the brain. We already talked about that a little bit when we were talking about like psychiatric conditions, right? Anxiety, PTSD, things like that. Play mechanisms. This one's great. Like there's a lot of studies that look at the actual neurocircuitry of play, which is really cool. And play is really important, especially in like young developing individuals, right? You want kids to engage in sometimes even rough and tumble play, right? It helps them kind of like figure out what the boundaries are, things that they do that might actually hurt somebody else, and maybe teach them to not do that again, right? You see that with dogs, right? If you ever take your dog to a dog park, dogs are always like rough and tumble playing. And it's a really good way for them to socialize. It makes them learn like limitations, like things that they shouldn't do, right? So they kind of teach each other that through rough and tumble play. Motivation, again, going back to the basal ganglia, and then memory, which is what we're going to be focusing primarily on for the rest of this next section. So this is a really fun video on perception. Like this is such a cool type of study. We're going to watch the whole video. It's 4 minutes long, but it's worth it.
Alone carry a lot of weight. Now, when the power of words combined with the power of authority, you can get people to believe just about anything. Dr. Wellman, I have an honorary degree in pseudoepistemology from the University of Phoenix. I placed an ad online inviting participants to take part in an experiment. So try a little experiment?
Okay.
Yeah, I'm going to make these people believe that this fake rubber prop is actually their real arm.
Seems unlikely.
This is a Fibonacci silk. Let me show you how it works. If I drape it like this, the gap is now gone between your shoulder and the rubber arm, and your brain kind of fills in the gap. It's called the Seinfeldian effect. Simultaneously, because you cannot see your real left arm, your brain disassociates that. That's called the Costanza effect. Wiggle the fingers on your right hand. Great. And now wiggle the fingers on your left hand. I'm going to attempt to establish a connection right now using these. I'm just going to rub the feather along a fake arm and your real arm that you cannot see. Your brain starts to connect the fake arm sensations and make them real. Now let's see how strong this connection is. Do you feel this?
Yes.
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 And that?
Yes.
And that?
That's cool.
Isn't that wild?
Yeah, it's fair. Because your hand is.
Yeah.
That's
The
weird.
brain
Yeah,
connects them.
that's interesting.
Let's just test how far that connection goes.
Okay.
The cold test. Now on your right hand, do you feel that?
I do.
Cold.
Yes.
That's why I call it the cold test.
Genius.
When I place it over here, how does that feel? Keep in mind, there's no science happening here. Just the power of magic and the power of BS. Now, what do you feel?
Nothing.
You don't feel an ice cube resting on top of your hand?
No.
Let's try another experiment. I call this one the heat test. Be very gentle. I promise not to burn you.
Okay.
Just curious if you feel that. What'd you feel?
A little bit of heat.
Tell me how this feels.
Ah!
Now, do you feel that?
No.
This?
No.
That?
Nope.
Pain test. For the pain test, I'm going to use this pointy needle. I'm curious. Do you feel that?
Yeah.
Isn't that wild?
Yeah.
What does this feel like?
Yeah, I can feel it.
Is it okay if I prick your real hand?
Yeah.
No blood, like acupuncture. Do you feel that? Nothing.
Nothing.
Do you feel that?
No.
How about that?
No.
Anything now?
No.
Nothing?
I know, right? I know. When I saw that, I couldn't believe it. I was like, wow.
Let's try something else.
I hope he sterilized those needles.
Ow! Oh!
You're good.
Oh.
Don't worry.
Wow.
Look at your fingers. Your hand's okay, right?
Oh.
If you don't mind stepping into testing room 2, we're going to collect a urine sample. Okay. It's in testing room 1.
Oh.
You know what happens in number 2.
Oh no.
Anyways, I know he's a wild dude. I know the needle one. I was like, that can't be real. Oh, it's real. He's actually inserting the needle. Like I said, I really hope he sterilized that, because you're technically supposed to put rubbing alcohol whenever you insert a needle into somebody. But I guess they don't necessarily do that in acupuncture, so I don't know.
We've always been.
And something else. Yeah, maybe. I don't know. So this whole documentary, like my goal was to actually integrate a bunch of clips throughout the semester in here, but I just didn't get a chance to, because it's hard to choose which ones are because the whole thing is great. Like, actually, for future classes, I might just say this will be a required watch for the class. But here's one clip. That being said, I highly recommend you guys watch the entire video. It's like 38 minutes long. It just talks about all different aspects of neuroscience. A lot of stuff that we actually talked about in this class, but they bring in like doctors from like Harvard and all sorts of different universities talking about like neuroscience, like really cool stuff.
We've always been really interested in why do people return the money when they don't have to, and guilt provides one plausible mechanism that might be driving their behavior to act cooperatively in this game.
So you're balancing making these decisions between getting that kind of dopamine reward hit from being a little selfish versus being balanced by those feelings of maybe guilt when you're not cooperating or helping somebody else out.
And the brain scans reveal which parts of the brain are most active when someone is feeling guilt.
Those regions end up being something called the insula. Signals about having this gut feeling that maybe this isn't a good idea or I'd feel really bad if I did that. Those are the signals that are originating from the insula that allow us to make decisions to avoid harming someone else.
Luke likes to think of it kind of like a thermometer and a thermostat.
But if you try to think about how a thermostat might be mapped onto the brain, we've always been really interested.
I highly recommend watching this entire documentary. It is super, super cool. Lots of really great stuff in there. And then this is just super cute. This is like studies that are done on rodent models, looking at actual like play pathways. They look at the way that the brains respond to play, and this is just awesome.
A tickle can send a rat into a fit of giggles. New research reveals what goes on in a rat's brain during a tickle. For Scientific American, this is Catherine Caruso. Scientists knew rats loved to be tickled, especially on their backs and bellies. A tickled rat lets out tiny giggles, too high for us to hear. Special microphones capture the squeaks so they can be replayed in a lower register. Belly and back tickles elicited giggles galore. Tail tickles? Not so much. The rats will chase a researcher's hand for more. And even frolic about in a newly described behavior called joy jumps. But only if the rats are in the mood to be tickled. A bright light at a platform make a rat anxious, and it won't giggle when tickled. Now, researchers linked these reactions to a specific brain region in the somatosensory cortex. Tickles activate these neurons. And stimulating those neurons makes the rats giggle, even when they aren't being tickled. Whether a rat can tickle itself is a question for future research.
So, if you don't like rats, hopefully maybe you like rats a little bit more now. Now you know that they can actually giggle and they like being tickled. I like rats a lot. I think they're so cool, and just in general, they're an amazing animal. They're very similar to their social hierarchies are very similar to like human social hierarchies. Like, have you guys ever seen? I think it's called Rat Empire or Rat Kingdom or something like that. It's a documentary that's actually I think on Netflix. If you get a chance to watch that, that's amazing. It's an amazing documentary, and it goes into like New York. It goes to in Louisiana. It goes to India, and it looks at how people treat, like, how they react to rats in different cultures and environments. And there's this one town in India where they kind of like think of the rats as being like sacred, like they're like the reincarnates of their ancestors. And there's this like area where they just have tons of rats everywhere, and people just go there to hang out with the rats, right? Just because they're like, oh, these are our dead ancestors. So really, really interesting. And the rats there are actually very friendly. Versus the rats in like New York, they're very intelligent, but they're not very friendly. Rats will literally, the older rats will literally wait until a young rat eats food and wait to see if the young rat dies, just to see if that's poison, right? Rats are smart, man. They're very, very smart. They're incredible animals. Yeah.
Put the link, because we don't have the decisions one, or maybe.
Oh,
would you be able to put that in the announcements for that documentary?
Yeah, I will. I will. It's such a good documentary. I highly recommend it. I think it's called Who's in Control.
Okay.
Oh yeah, Your Brain, Who's in Control.
Okay.
Yeah, you can watch the whole thing on YouTube for free. All right, one of my favorite guys. I'm gonna bring him up again, Dr. Mark Solms. I finished his book that he wrote with Turnbull. Finally, a couple weeks ago. Really, I highly recommend reading this book. It's The Brain and the Inner World. The Epstein that didn't kill himself, you're talking about? Oh, yeah. That's very funny. Yeah, I hope he's not like Epstein. So on perception and consciousness. So the sole purpose of perception is the guidance of action. And the whole idea here is perception of emotion, right? Emotions are going to be like a guiding force for your perception. So they both work hand in hand. We see also what we expect to see, right? And he talks about like blind spots. Remember, we have that natural blind spot in our eyes from our retinas, right? Where is that from? Where's that blind spot? Just if you guys remember. It's not the fovea. The fovea is where you have the highest concentration of cones. Yes, the optic disc. Good job. That's awesome. Yeah, that's where you get cranial nerve number 2 going in. Right, so that's the blind spot. And your brain literally just fills that in. And so he considers this as a top-down influence on visual perception. Again, this is from Dr. Solms' book, Emotions and Consciousness. Emotions are real. How can something immaterial affect something material unless it is real? The answer is obvious. Of course it's real. Reality is not synonymous with visibility. Feelings are real. They exist. They have effects. And for that reason, science ignores them at its peril. And it's true. Your emotions are going to affect your body, right? That's why we have psychosomatic conditions. They are real, right? If you have anxiety, depression, those things are going to start to manifest in like physical symptoms. And sorry, you had a question?
I was going to say, you should put that Carl Jung quote. I'll send it to you later.
Oh, yeah.
That's like things in fantasy, like everything was created because of stuff like emotions that are not physical, you know. But
can you send that to me? Make a note of that and send that to me. I'll definitely include that because Carl Jung is like my favorite of all psychologists in general. He's an amazing guy. But also, it's like, God, Bentov. I have a hard time pronouncing his first name, but Bentov, Itzhak. So he's Israeli scientist, right? He actually was an inventor. He worked with the Israeli military to develop like even weaponry that he didn't really want to talk about it while he was alive. Unfortunately, his life was cut short in a really nasty plane accident. But he wrote this really amazing book, Stalking the Wild Pendulum. I highly recommend reading it. And he talks about stress, and stress accumulates in the body. Stress, they're imprinted on the physical body just like music is imprinted on a phonograph record, which is true. It's a really great analogy. Things like high blood pressure, heart attacks, right? They can all be things that manifest after long-term stress, right? Cortisol release has been found to cause, over time, hyperglycemia, right? Cortisol is a glucocorticoid. One of the things it does, it increases glucose. And we all know that glucose in high amounts over a long period of time is really damaging to the body. It can cause cerebrovascular disease, heart attack, stroke, etc. Stomach ulcers and other ailments, right? Anxiety can basically cause stomach ulcerations. It's been known for a very, very long time. So in other words, psychosomatic diseases are an index of the amount of stress in the body. So on dreams, this is from Dr. Solms' book. So he did a whole entire section on dreams, and lots of dream studies were started when they were doing lobotomies. So lobotomies, eventually they started referring to them as leucotomies because lobotomy wouldn't wipe out the gray matter. They wanted to wipe out the white matter tracts. And so that's why they call it a leucotomy. And you can actually like buy a leucotome, which is like, you can actually buy it on the websites. They have like vintage leucotomes you can buy. There's this one website that sells all these like really interesting, like obscure science, like historical like artifacts and stuff. And you can buy a leucotome. So pretty dark. If you're into like dark medical history, like those kinds of things are very interesting. But the studies done in the 1950s with frontal leucotomies, they would stop the patient from dreaming altogether. And these leucotomies were originally done to treat like psychosis, like legit psychiatric conditions, schizophrenia, psychosis. And then people just started using leucotomies for everything, right? Like John F. Kennedy's sister, for example, where she got a lobotomy because she was acting a little, she had too much freedom, or she was just acting like too crazy or whatever. and then they just did a lobotomy on her. So it was like very much heavily abused, and it was like an awful procedure in general. But we learned a lot about the dream landscape and how dreams are formed in the brain because of some of these early studies in leucotomies. As it was so much so that if the patient still continued to dream after getting lobotomy, that was considered a poor prognosis for the procedure, showing that the procedure didn't actually wasn't like completed properly, right? So it actually, the procedure failed. So they used to use that kind of like as a diagnostic tool. And then in schizophrenia, schizophrenia is kind of like an individual having dreams, but during their waking life. Right? It's like their dream world is like basically manifesting before their eyes. So dreaming in schizophrenia, the functional anatomy of dreaming is therefore almost identical to that of schizophrenic psychosis, as revealed by functional MRI studies. One substantial difference is that in schizophrenia, it is primarily the audio-verbal components of the perceptual system that's activated rather than the visual-spatial. That's not always the case, though. In severe schizophrenia, you do get visual hallucinations. Often, however, it's going to be more like auditory hallucinations. And then he closes by saying, dreams truly do appear to be the insanity of the normal man. So, memory and emotions, right? Memory and emotions are very, very tightly interconnected. So the network of structures that comprise the limbic system was first identified not in connection with the function of memory, but rather in connection with emotion. Right? Limbic system is very much involved in emotion, especially like the amygdala, for example. Episodic memories are not simply stored, but rather lived. The essence of episodic memory is that it is conscious, and the essence of self-generated states of consciousness is that they are intrinsically emotional. Consciousness is both the medium and the message of episodic memory. We retrieve events in the episodic form in order to remember what they felt like. Right? So actually experiencing the sentiments of those memories is what's key in memory retrieval. And then long-term memory. So here's a really interesting law, right? So Ribot's law. This has to do with remote memories, right? Memories of things that are way in the past. And this has to do with Theodule Ribot in the 1880s. So the most recent memories are the ones that are most vulnerable to loss, right? We easily forget things in our recent memory, right? Whereas things that are much more remote and further away in our past, those are the memories that stick the most. Those are the ones that are more durable, as Dr. Solms and Turnbull say here. Memories are continually being consolidated to deeper and deeper levels of storage. So you have to have deep levels of storage. Right, we're going to talk about Alzheimer's a little bit, maybe a little bit today, more so maybe next week. But with Alzheimer's, the first thing to go is your anterograde memory. Someone tells you something, maybe they tell you their name, maybe they, you learn something new. That's the first memory to go. You forget that right away with early stage Alzheimer's. With later stage Alzheimer's, you start forgetting things from the past. And that's when things get really sad, right? We've all known someone in our lives, or at least heard of someone in our circles that has gone through Alzheimer's, and then they start forgetting their kid's name, they start forgetting their spouse's name. Right? That's really sad, right? When you actually start forgetting who your closest relatives are. This is such an interesting study done by Claparède, I think is his name, or how you pronounce it. It's French. So Dr. Claparède was a Swiss neurologist, and there was a patient that he had that had really bad amnesia, really bad anterograde amnesia. So she was wouldn't form any new memories whatsoever. So he put a little pin in his hand, and so he would go to shake her hand, and it would hurt, right? She would get pinpricked. And so it would elicit some pain, but then shortly after, the patient totally forgot what just happened. Okay? Then he would go to shake the lady's hand again, and she would withdraw her hand. She would not shake his hands anymore. Even though she didn't actually remember actively what happened, she intrinsically knew what happened. Right? So these are different types of memory formation. So when asked why she refused to take his hand, the patient just said, one has the right to withdraw one's hand. And there was another quote I saw online of one of her quotes. She was like, Sometimes individuals hide pins in their hands. She didn't know it was him. She just had this like weird kind of like, it's almost like a truism or something. Like people sometimes just have pins in their hands. Like, not exactly, but so super interesting. This is the association between episodic and semantic memory. So we're going to talk about different types of memory momentarily, but super interesting stuff. So that's Dr. Claparède's work. And here you go. Here's different types of memory. So I guess first, before we talk about the chart, memories are going to be, involves acquiring memories, retaining, and recovering data that defines a person's identity. These are the ways that memory is going to be stored: encoding, consolidation, recovery, and reconsolidation. So this is kind of an overview of different types of memory. So you're going to have working memory and long-term memory, right? You can think about this kind of like a way a computer works, right? Your RAM is your working memory. So if you have like 8 gigs of RAM on your computer, and then you upgrade it to like 16 gigs of RAM, your computer is going to work faster because it's going to have a lot more working memory. If you change your hard drive from like 250 gigabytes to maybe a terabyte, that is considered more like a long-term memory, right? Your brain does that too. Your brain stores long-term memory. It's not just the hippocampus, but it's going to be other parts of the cerebral cortex as well. Right? Short-term memory, working memory, is very much going to be involved with the hippocampus. But then if you want to really truly store memory, it has to go beyond the hippocampus. It has to be stored in other cortical regions in your brain as well. And then of long-term memory, you have 2 different categories. You're going to have declarative or explicit versus non-declarative or implicit. Declarative, explicit memory, think about episodic memory, events. Yesterday I had an omelet for breakfast, then I walked my dog, then I saw my dog get hit by a bus, and, stuff like that. That didn't actually happen, thank God. Semantic memory, this is facts. United States was founded in 1776, right? Stuff like that. The name of your first president, right? George Washington. So like things like that. That's going to be more semantic memories. Then you have non-declarative, declarative implicit memories. And that's going to involve, we'll talk about priming later on, but skill learning. So if you learn how to like ride a bike, if you learn how to ride a skateboard, these are skills that you develop, and this is considered a type of memory, but it's non-declarative, right? Conditioning is also going to be in that category as well. And we looked at Pavlov's dog a couple weeks ago with classical conditioning. That's very similar, right? You start associating things with, you start associating a stimulus with another stimulus, right? So there, I'm going to show you in a little bit, like different studies they've done on rats, for example, where they will shock a rat, but then also simultaneously like show a certain color. They'll shock the rat while they're simultaneously showing a certain color, like blue, for example. The rat starts getting really nervous and anxious, right? Because it's starting to associate those stimuli together. All of a sudden, if you just show the rat the blue color, it's also going to be like anxious and it's going to freeze. And you'll be like, what's going on here? That's conditioning, right? That's a learned behavior. And so that's part of your non-declarative type memory formation. So that's long-term memory. Short-term memory, again, is working memory versus long-term memory. That's all these other types, declarative, non-declarative. With working memory, which is short-term memory, that's going to be seconds to minutes, right? It doesn't last very long. If you have cognitive dysfunctions, that could be associated with short-term memory deficits. The regions of the brain that are going to be associated with this would be the lateral prefrontal cortex. And here's a study that was done. Let's see, these are patients, impaired working memory versus preserved declarative memory. And so percent correct here on the top right. So you had working memory, so word span. So this is the control. An individual had normal working memory with word span compared to declarative memory. This is when you're learning a 10-word list. And so if you're learning new memories and you don't have any, dysfunction with your declarative memory, then both the experiments as well as the controls are going to be, working pretty well together. And then you have amnesia over here, preserved working memory versus impaired declarative memory. the amnesia, even if they're like trying to learn new like digits, for example, they're going to have a really hard time with that, right? With amnesia. Consolidation is going to be really important too, right? Consolidation is where you actually start to, ingrain those memories in different regions in your brain, right? Not just the hippocampus, but also within different cortical layers of your brain. So consolidation, particularly when you're sleeping, right? During REM sleep, this is especially when you get a lot of consolidation of memories. And so here's a nice little schematic talking about how the hippocampus is going to be associated with other parts of the brain, right? So you're going to have the hippocampus sending basically information to different cortical layers so you can get storage of long-term memory. Cingulate gyrus, right? The cingulate gyrus is going to be like emotional connection with memories and things like that. Now, with priming, priming is a way that you can basically kind of like prime an individual to remember something, right? So it's not reliable, but it can be resistant to injury and aging and dementia. So you like, for example, let me think about like my dad, for example. He's got really bad memory at this point. He's got advanced dementia, and he also had a stroke a year and a half ago. You have to prime him to like remember things. Like when we're going to visit my mom in the town that I grew up in, I'm like, hey, last weekend I was like, hey, what town are we in right now? And he's like, oh, I don't know. I'm like, yeah, you do. You lived here for like 30 years. You should remember the name of this town. And I'm like, it starts with an F, right? And then Fountain. And he's like, Fountain Hills, right? So you have to kind of like prime the individual, right? Try to like help to jog their memory a little bit, right? So that's priming. And they've done studies in priming, right? Looking at lists of words and then testing the words that they actually remember. And sometimes they'll have to actually prime the participant with like maybe the first portion of the word and to fill out the rest of the blank, right? So they can like try to remember what the rest of the word was. And so there's a bunch of studies that are actually in your textbook that you can read through if you're interested in this kind of stuff. Super fascinating, right? Priming type studies. Non-declarative brain regions, it's going to be a bunch of different areas. So basal ganglia, right? Motor learning, right? We talked about how when you're learning skills, you're developing habits, it's going to be involving the basal ganglia. Also, different regions of the brain, especially like the prefrontal cortex, is going to be important in that. The amygdala, sensory association cortices, cerebellum, right? These areas are going to be very important in non-declarative type of memory. So if you learn how, for example, to ride a bicycle, you need to have all these regions playing together. If you learn how to play an instrument, all these areas are going to have to work together. Actually, instruments are even more interesting because it involves not just these brain regions, it also involves the occipital lobe, it involves part of the temporal lobe for hearing, right? So you're like seeing, you're hearing, you're moving, right? You're integrating so many different regions of your brain. And then the basal ganglia, right? You're strengthening all those connections. So super cool stuff. So that's non-declarative memory. Think about like skill learning. And here's another example of priming over here. So this is the test, right? This is at the second time when the person's like being exposed to these words. If they're prompted with at least a portion of the word, they would usually be able to fill out the rest of it, right? So long as they've been primed, right? The person who's primed with, for example, a list of these portions of the word, they're going to be able to recall at a much greater rate. Okay, so that's kind of the effects of priming. So really cool stuff. So it can basically help jog people's memory. So this is where we stopped last time. We were talking about the effects of priming. So when you prime somebody you give them a list of words that they can read, and you can even go the next day, test to see if they remember those words. And you prime them by just like literally giving them a small section of those words, a couple letters, and then that really helps to remember what those words are. So you can compare groups that were primed versus groups that were not primed, and you can see that they performed significantly better when they were primed with at least a portion of the word. Now, when it comes to learning, learning has been studied by people like Skinner, for example, Dr. Skinner, who did a lot of studies using rats. This is a pretty typical Skinner type box where you have the rat maybe perhaps like push a lever where it gets rewarded with food. There's even been studies done where they're comparing rats with like comparing food with drugs, for example, to see which one the rat would prefer to, preferentially choose. There's been studies done, for example, where they either give food or cocaine to rats, and the rats will literally choose cocaine to the point where they die. But these types of studies were they don't give you like a full picture, right? Because if you actually give a rat a really nice social type setting, the rat will actually choose food over cocaine, right? It's only when they're put in isolation, for example, like in this tiny little box here, where they're not exactly getting a rich social type experience, or they would choose drugs over food. So interesting studies, right? But it does give you some idea of how you can, train animals. I mean, for this is called operant conditioning. So literally you give them like rewards or punishment, right? So fun stuff. If you basically remove a behavior, right, that's called extinction, right? So you can train an animal to behave in a certain way, but then you can also untrain them, right? So that's called extinction. Now, in terms of motivation, I mean, I'm sure a lot of you guys in here have a pet, maybe like a dog, right? Animals are very much food motivated, right? When I used to have a dog, I would, train her using like little bits of treats and things like that to learn how to shake my hand, give me a high five, all that stuff, right? So food is a huge motivating factor. It's also a motivating factor for us as well. There's been studies where they'll have different groups and they'll have them remember things that either pertain to food or maybe pertain to other objects. And then they'll have one group be fed, but then the other group go into it in a fasting state. And those who are in a fasting state will remember food-related items on like memory tests, much more so than those groups that were actually well-fed before the actual study took place. So in other words, if you're really hungry, you're going to remember things that are pertaining to food-related memory cues. So really interesting stuff. So it's not just animals, we're also very similar. I mean, there's also been studies done on like judges and what kind of punishments they dish out, like before lunch versus after lunch. Before lunch, like right before lunch, judges tend to be really cruel in their, what do you call it, whenever they actually like do a sentencing. Yeah, they're very cruel in their sentencing. Whereas after they had their meal, they're like satiated now, they're happy, their sentencing is way less severe after lunch. I mean, they've done these studies about a decade back, and those studies are really, really fascinating. So, food definitely is a huge motivating factor. Savant syndrome. This is a really, really rare thing. Generally speaking, it's going to be associated with patients who are in the autistic spectrum disorder, right? On the spectrum. This guy is an amazing dude. He's a phenomenal pianist. Absolutely phenomenal. He can listen to a bunch of wrong notes being played, and he can literally pick out, just by hearing it, all the wrong notes. Plus, he's blind. So it's not like he's actually seeing the person play the notes. So this is a really fun video. There's tons of these videos online where he can just like listening to like a little tune, and he'll just like improvise on that tune, like on the spot. Just absolutely incredible piano player. So let's watch a little video on him. Oh man, sorry. Let me give me 1 second to log in here. Start without data. Hopefully. Okay, hold on 1 second. Let me turn this up. These computers have been logging me out of all my information for some reason. It's been so frustrating. So this guy in the back playing like a little tiny melody, not the greatest melody ever, but then when he starts playing over that melody, just absolutely insane. So just incredible. Absolutely incredible. I mean, he does stuff like that all the time. He does tons of videos. If you want to watch more videos like that, it's just awesome. So that's a very rare thing to see. Right? Did you have a question? Oh, okay. So other things that are important for memory, right? Like motivating factors, like you have your endogenous reward system, right? We talked about it quite a bit already, like the basal ganglia and all of that. The ventral tegmental area, which we talked about quite a bit, that's one of the other areas where you see dopamine being involved. Right? So ventral tegmental area, substantia nigra and the ventral tegmental area are both areas that are going to be very important for reward and dopamine production. So you get lots of activation of the VTA, and that's going to help to basically allow for memory consolidation. So learning new things is important, but also forgetting things is equally important. You don't want to keep every single thing that you've ever experienced in your life in memory, right? Otherwise, you're going to be flooding your mind with a bunch of unnecessary information. So use it or lose it is actually a good thing, right? If you don't use a skill, you're eventually going to forget it, which is perfectly natural. So that's absolutely fine for that to happen. This is adaptive. You have to have that. If you keep too much memory, then all of a sudden it's kind of like a hard drive on your computer, right? You don't want to have it just completely packed full of stuff. Your computer is not going to work properly, right? So losing memory is very important. So this is a study that's looking at over a course of 15 years where participants were asked to actually recognize names of a television program. So over time, people continually forget that unnecessary information. This is also interesting. Like your hippocampus can actually be hypertrophied depending on what kind of things you're asked to remember. Taxi cab drivers have, the ones in London, they have to go through one of the most difficult, challenging exams before they can actually qualify to get a license to be a taxi cab driver. They literally have to remember every single street in London. And they need to be able to figure out alternative routes. Right? I can't remember which podcast it was. I was listening to a podcast about this, where they were going through the kind of things that they need to learn. Not just the street names, but also if there was a traffic jam in this one location, what would be the best alternate route? And then the cab driver would have to come up with it on the fly. Just absolutely insane. And so when they did studies on these cab drivers, I'm going to play you a video in a second. When they did these studies on the cab drivers, they noticed that the posterior hippocampus was the region that was mostly hypertrophied in these individuals compared to, the normal population. So let's watch a little video on this. Let me see. Oh, it's not a video. Never mind. There's an image. There are videos about these exams, and it's really, really interesting. So if you're interested in, how London cab drivers will have, increased hippocampus size, Google search those. But super cool stuff. In terms of changes over your lifetime, brain size, so brain mass, will peak between ages 20 to 25. Right? They say that, once you turn 25, that's when your brain has fully reached maturation, which is one of the reasons why, it's advised not to do drugs or alcohol or anything like that when you're in your teens, right? Even though a lot of people do, right? But if you start, damaging any of your brain cells in your teens, that's not a good thing. Your brain hasn't reached full maturation yet. So 20 to 25, that's about the time when you get full maturation. And then over, the ensuing decades, then you start seeing brain mass slowly begin to atrophy. Right? That's normal part of aging. The brain mass will diminish in size. Right? That can just be part of regular aging. Of course, that's going to be much worse in patients with Huntington's disease or Parkinson's, Alzheimer's, etc. So it is normal to lose some brain mass. Here are the regions that are lighting up due to memory recall. So this is a younger individual. The prefrontal cortex, just a little portion of the prefrontal cortex is lighting up in a younger individual. An older individual that doesn't have really great memory also will have a little bit of regions lighting up in the prefrontal cortex. But if you're older and you have really good recollection, you get basically bilateral activation of the prefrontal cortex to remember, to recall different things. Now, let's get more into dementia. We're going to talk about Alzheimer's and Lewy body dementia, where Parkinson's also falls into that category as well. But we already talked about Parkinson's in the basal ganglia section. Dementia does affect many, many individuals. So 2015, 47 million people were suffering from dementia. Now, this is not senile dementia. This is like actual full-blown Alzheimer's, right? This is legit dementia where you need to actually get assistance, right? You need to get, skilled nursing or, be living in a group home type of scenario. This number is going to grow tremendously by 2050, right? I mean, as the population grows, and especially as the population ages, right? We have, over the past several decades, the life expectancy has gone up, except for, I think it was either last year or 2 years ago, it finally dipped. Why was that? Do you guys,
Obesity.
Huh?
That's what they told us.
Obesity?
Wait,
No, not necessarily obesity. The life expectancy dipped over the past couple of years. Not COVID. I'm sure obesity has a part of it too, but drug overdoses. Drug overdoses. Yeah, so fentanyl, drug overdoses. It looks like 110 or 120,000 people last year died of drug overdose. And these are like deaths of despair. And those are on the rise, right? Especially with the fentanyl crisis. But yeah, obesity would certainly contribute to that as well. So I'm sure it's multifactorial. But regardless, I mean, with modern medicine, like life expectancy has been going up at least, steadily until a couple years ago. Dementia is age dependent. The older you get, the more likely you are to develop dementia. So the incidence will double every 6 years, basically. Every 6 years of age, it doubles. It costs a lot, right? It's a huge economic and financial burden on society. So you think about home health aides, skilled nursing facilities, right? All those cost tons of money. For example, like when my father and even like the lady that he was with for like 20 years, when she started developing dementia, he also started developing dementia. I mean, getting home health aid for them was very expensive. And now, my father's living in a kind of a group home type setting, and it's pricey, right? It costs a lot of money. So this is definitely something that we all have to contend with, right? Contend with as a society. These are the activities of daily living compared to instrumental activities of daily living. So ADLs will be anything that we all basically take for granted. Things like showering, feeding, right? Grooming. Sometimes a person will basically lose the ability to actually take care of themselves. Basic stuff, grooming, toileting, using the bathroom, walking, climbing stairs, right? If your ADLs start getting impacted, you need to have some sort of intervention at that point. Instrumental activities of daily living, this would be like going out, shopping, cooking, med management, all that stuff. So it's actually like doing like chores, basically, is the instrumental activities of daily living. When an individual is beginning to get dementia, compared to an individual who's basically just having like normal age-related memory loss, a person who has normal age-related memory loss, they're going to start noticing that they're forgetting things. Right? They start forgetting words, they start forgetting places, they might start forgetting people, but they're aware of it. They know that there's something going on. Whereas a person with dementia, they forget stuff, but they don't know about it. Like they're not aware, they're not self-aware. It's other people around them, their family members. They start noticing, Uncle Bob is starting to like lose his memory, right? Like for example, my dad, he would, before he had a stroke, he would like tell the same story over and over and over again. And it was cool because I loved it. I loved hearing him telling about these stories of like his past, places that he lived and stuff. And I would even record them without him knowing, just, because at some point in the future, I want to look back on that. But I would never tell him, oh, I already heard that story, Dad. Right? I would never say that. I would just I would pretend that this is the first time I ever heard it. Right? And that's kind of how you want to treat individuals with dementia. You want to be like very respectful and courteous. Right? It's really sad when, I'm sure you guys all seen like an old couple where one person, like the husband, is developing dementia and the wife is like always criticizing him for it, right? Or the other way around. So that's really sad. You want to be like supportive of your family members who are going through things like this because, it at some point could happen to you when you're older too. So, what else? Losing not being able to recall words, getting lost in familiar territory. That's like one of the saddest things. Is like this happened to one of my neighbors. They had to get their car taken away from them because they got lost. Not my neighbor. This is where I grew up, but my mom is like my mother's neighbor. She got lost like literally a mile down the road at the Target, and she like didn't know where she was. It was like half a mile to a mile down the street, completely lost, like totally wild. So that's all the kind of stuff that you would see with actual legit dementia, where the ADLs are being affected. Delirium versus dementia. It's a good thing to distinguish between these two because they're quite different. Delirium is going to be an acute type of thing, right? So this can happen if you have an infection. If you have an infection and you're like maybe you're febrile, like your temperature is really high, you might become delirious, right? You might start hallucinating. You might just have an altered mental status, basically, or AMS is what they call that. It could be drug-induced, right? You could be in maybe a drug-induced psychosis, perhaps. There's a lot of things that can cause delirium, but it's acute, it's transient, and eventually it will subside. Now, dementia, that does not subside, right? And it's not the normal part of aging, right? Alzheimer's, Huntington's, things like that are going to be what would cause actual full-blown dementia. And they are progressive conditions. They get worse and worse and worse as the years go by. Amnesia, retrograde versus anterograde amnesia. If you have retrograde amnesia, that means that you are forgetting the things from the past. Remember that memories that are formed way deep in the past are the ones that are more stronger, right? Those actually stick longer. Whereas the newly formed memories are the ones that you lose first. Those are the most vulnerable of all of the memories. So retrograde amnesia, losing things in the past. You can get this from trauma, right? You can get this from Alzheimer's, obviously, right? With Alzheimer's, you start noticing that they're forgetting like recently learned things or recently learned information. But then advanced stage Alzheimer's, they're going to start forgetting like their brothers. They're going to start forgetting their sister, their mom, their dad, their children, all that stuff. They're going to like forget the people who are closest to them. So that's when it's really, really bad. Electroconvulsive therapy, shock therapy. It's still used today. It's used to treat things like refractory depression, and it's actually very effective. Right? It's not like what you see in the movies, where you like get held down and they just start shocking your brain. Right? They actually put you under. They put you under general anesthesia, so you're completely unconscious, and then they basically do electroconvulsive therapy, and it can really help patients with refractory depression and some other conditions too. But with depression, it doesn't last a very long time. You have to keep on getting it done. You have to get it done about once a month or so. And it actually works. But when you get ECT, you actually do get amnesia. So you're going to see both anterograde and retrograde amnesia after getting electroconvulsive therapy. All right, Alzheimer's disease. So now let's focus on Alzheimer's. Causes can be unknown or they can be multifactorial. Right? There's certain risk factors for Alzheimer's. So one example would be age, obviously. But females tend to develop Alzheimer's at a higher rate than men. Also, genetics can predispose an individual to Alzheimer's. Chromosome 21. Where have we seen chromosome 21 before? Down syndrome, absolutely. Trisomy 21. Down syndrome patients have a much higher propensity of developing Alzheimer's. So, the apoprotein. So, apoprotein E4 is going to be a huge risk factor. So, this is a genetic mutation of the apoprotein gene. What does the apoprotein do? It's basically just like a transporter for cholesterol. Now, some people have a mutation in this, and that predisposes an individual to Alzheimer's tremendously. Presenilin is going to be another thing that accumulates as well. You see this especially with head trauma, right? Low education. Why do we say low education? Sort of. What's something that can help you like prevent the development of Alzheimer's? It's like something that we're all doing right now. Yeah, learning new skills, learning new things, learning new trades. I always tell my students, like, learn an instrument. Learn multiple instruments. Learn a new language. Learn different things that are going to help like strengthen your memory and strengthen your cognition. There's a lot of studies done on learning and how it really helps to mitigate Alzheimer's, and especially when it involves something that's like a very like hands-on type of thing, right? You can read books, you can learn, you can do like Sudoku puzzles and stuff like that. But if you like learn a trade or a skill or something like that, that really helps because now you're engaging multiple different regions in your brain. I'm going to show you a little thing about that regarding music in a second. What are you going to see in Alzheimer's disease? You're going to see atrophy of many different regions of the brain. Generally speaking, you're going to see widening of the sulci and atrophy of the gyri, right? So smaller gyri, widened sulci, right? That's because like the brain's just shrinking in general, and now all that extra space is going to be taken up by CSF. You especially see this in the cerebral cortex and the hippocampus, amygdala, right? What do you see on biopsy? So you don't do a biopsy on an Alzheimer's patient. You do this post-mortem. You look at their brain underneath, you do like little cross sections and do histology. You would see neurofibrillary tangles and amyloid plaques, beta amyloid plaques specifically. Those are the two hallmarks of Alzheimer's disease. Genetics, again, the ApoE gene, if you get that mutated, that's a huge, huge problem, right? That's going to predispose an individual to Alzheimer's. There's also the APP gene as well, but the ApoE gene is really, really tightly linked. So again, widespread atrophy of the brain, thin gyri, wide sulci, the ventricles, again, very similar to the other scans that we saw of Huntington's as well as Parkinson's. You see the brain atrophy, the ventricles all of a sudden look larger than they otherwise would. Again, neurofibrillary tangles, these are made up of tau proteins, and what these are just basically misfolded proteins. So beta amyloid and neurofibrillary tangles basically misfold, they accumulate, and they start destroying the neurons. Beta amyloid plaques are going to interfere with action potentials, and neurofibrillary tangles are basically going to just cause the cells to die. So it does cause neuronal death. And this is the main thing, is acetylcholine. So put a star right there. I want you to make sure that you know acetylcholine is the primary neurotransmitter involved in Alzheimer's. So, with that being said, what would be a potential treatment option for patients with Alzheimer's? If acetylcholine is the issue, then what can you do? Can you just give them acetylcholine? Not really. You'd want to increase the levels of acetylcholine, right? So what could you use? Thank you. Yes. Acetylcholine esterase inhibitors, right? That's how you're going to start treating these Alzheimer's patients. Are they like the end-all be-all? Is it going to make the person miraculously improve? Is it going to cure Alzheimer's? Absolutely not. But it's going to help alleviate some of those really severe symptoms. And there's a lot of other things too. There's lots of research being done on Alzheimer's. When I went to the Arizona Alzheimer's Consortium last year, they hold it annually at ASU. If you're interested in neuroscience, I highly recommend going there. Actually, I saw a couple GCU students there. So it's a great, great convention. And they have excellent speakers doing wonderful research. They have also like poster presentations from like student researchers, undergrad and graduate level researchers. Super cool stuff. One of the doctors, he works at Banner, part of the Alzheimer's unit. One of the doctors, his study was looking at blood pressure and bringing down systolic blood pressure. From his study, he saw like, significant improvements in the Alzheimer's symptoms. His big thing was like, right now it's systolic of 130 and above. That's considered hypertension. He thinks that the systolic should be less than that to be, diagnosable hypertension, right? Because if you have hypertension, that can affect lots of parts of your body, right? And what does hypertension do at the cardiovascular level, right? What does it do to the capillaries? No, it destroys them. Hypertension destroys capillaries, right? You get atherosclerosis as well, right? You start getting when you say sclerosis, you mean hardening of the arteries, right? And so plaque formation, right? So Alzheimer's could partially be due to, it could be partially cardiovascular as well. So I talked to him afterwards. I was like, that's a really interesting, I never heard about that before. I never heard blood pressure in Alzheimer's, but it's a risk factor. Hypertension is a risk factor for Alzheimer's. So there's got to be a vascular component to it as well. So it's multifactorial. There's a lot of things going on with Alzheimer's. Again, music. So not just listening to music, playing music, learning how to do an instrument, right? You're literally using so many regions of your brain. Let's think about some of them. What are the regions that you think you'd be using when you're playing music? Frontal lobe, for sure. Absolutely. Higher executive function. Memory as well. What else? Do you have to see what you're playing? I mean, you don't have to. I mean, you can be blind and play, right? Ray Charles, great example. Lots of blind artists. But generally speaking, you're like looking at what you're doing, right? If you're playing the guitar, the piano, or whatever. So you're using what lobe? Occipital lobe, good. Then what else do you do? What's the purpose of music in general? Hearing, yeah. So what area in the brain is going to be responsible for that? Yeah, what you find in the temporal lobe, right? What else happens when you're like learning how to play music? Dopamine for sure, yeah, because when you're learning something new, learning new skills. What else are you engaging? If you're learning something.
Amygdala to tell you if it's fearful or not?
Well, more so the hippocampus. Yeah, the hippocampus for sure. I mean, you're using all these regions of their brain, right? And then think about the tactile sensation of the instrument. What does that do? What area does that activate? Just feeling it. Primary somatosensory cortex. Which lobe is that? Parietal lobe. Did we just list off basically all the major lobes of the brain? Absolutely. Yeah, so learning how to play an instrument, man, like, I don't care if you suck at the guitar. Just do it, right? Learn an instrument, even if it's badly, just so you can, like, engage in something new. So I encourage that of, like, my students. I encourage that of my colleagues. You know, I have some colleagues even, like, do you guys know, I think his name is Dale Landier? Dale, yeah. He, like, came into my office. He's like, what kind of tips do you have to learn how to play the guitar? And I'm like, I will help you, man. Just get a guitar, bring it in, and I'll literally show you chords. I was teaching music before I started working here. So I'm more than happy to even, like, teach my colleagues how to play an instrument. Even if it's badly, like I said, just learn a couple chords. Super fun. And then you can be like the really annoying person at a party that, like, you know, plays music and stuff. These are the 5 A's of Alzheimer's: amnesia, anomia, which is where you can't name something, apraxia, meaning that you can't do something, right? So you're losing the ability to perform a skill. For example, like writing. Literally writing would be something that you would test in apraxia. Agnosia, inability to recognize an object. You know, if you do like a test for this, you'd be like, you know, what's this? And then they'll be like, I don't know, it's an umbrella, right? That would be agnosia. They're not able to name an item. It's a pen. Is this the pen? No, it's not even the one to use for it. Aphasia, right? We already talked about aphasia, like Broca's, Wernicke's, right? This is similar, right? They're not able to say the words, right? They can't find the words. So those are the 5 A's of Alzheimer's. They get mood swings. They get agitated. It's very common, especially for sundowning. You guys familiar with sundowning? What is sundowning? For those of you who aren't familiar, you shook your head. What's sundowning? Yeah, absolutely. They get way worse at night. And around like 5 o'clock or so, right? Why do you think that is? It has something to do with melatonin, like circadian rhythm, you know, day and night cycle, right? And so for whatever reason, they get really bad sundowning. Impaired judgment, obviously. Sometimes they get depressed. Again, ADLs and IADLs will get affected. This one's so funny. Who used to call it Alzheimer's disease? Yeah, me too. I used to call it Alzheimer's disease. That's literally what I thought it was. I even had like one of my students say that, like, oh, so what's up with Alzheimer's disease? I'm like, this is one of my pathology students. This semester actually said that. And I was like, I didn't correct them, but I was just thinking like, dude, you just learned about Alzheimer's in this class. Like, why are you still calling it Alzheimer's? How do you test for Alzheimer's in a clinical setting? You do the mini mental status exam. So this is the mini mental status exam. I highly recommend printing this out. Next time you guys go to like Thanksgiving dinner, right? Maybe you see grandpa at the table, you're like, hey, grandpa, I kind of want to do this test on you. My professor told me to do it. So this is the mini mental status exam. You ask them the year, season, maybe the day, the month, right? You ask them where they're at currently, right? I'm at the Thanksgiving dinner table. You have them you have them remember 3 objects. It could be they have to be unrelated, right? So you could say, remember these 3 words, repeat them after I say them, and then remember them so that like in about 10 minutes or so, I'm going to ask you those words again. And you say like tree, desk, building, I don't know. And then you have them repeat those words, see if they have any difficulty saying those words, and then a couple of minutes later, you'll have them remember those words again. When I used to do my clinics, sometimes I would forget to ask them what those 3 words were. So you got to remember to ask them again what those 3 words were. This one, spell world backwards. Yeah, that's a good one. This is the one that I don't like. I would like it to count backwards from 100 by 7s. So it's like 100, 93, and now I'm lost. I can't go back any further. So I never used to use that one just because I can't do it. I'm just like, dude, if I can't do it, I'm not going to expect somebody else to do it. So world backwards is much better. And then you have them remember those words again. Have them identify objects. Have them repeat phrases like no ifs, ands, or buts. Right? Maybe like some sort of tongue twister type of thing. Have them do a simple command. Say, take this piece of paper with one hand, fold it, and then place it down on the table with the other hand. Right? Something simple, like a simple task. See if they can actually do a command. Please read the words and like follow the instructions to see if they can actually read. So they have like verbal comprehension. See if they can follow the instructions. Make up and write a sentence about anything, right? Just to see if they can come up with creative ideas and stuff. And then this one. Have them draw 2 intersecting pentagons, not pentagrams. I said that in my patho class. No pentagrams. This is a Christian institution. So 2 intersecting pentagons that connect at 2 different lines, right? And so basically if they can draw that, they're good. And you can look online to see some examples of like really bad, like advanced staged Alzheimer's, and they won't be able to do that whatsoever. And so you can rate them, so you can score them to see how severe. It could be mild, could be moderate, or it could be severe, dementia and memory deficit. So that's the mini mental status exam. And this is actually used. This is used in every psychiatric and neurological clinic, right? So a very, very commonly used questionnaire. Complications of Alzheimer's, over time, the individual is going to die from it. How does it happen? They literally forget how to swallow their food. So they can no longer swallow their food, so they aspirate. Pneumonia is going to be really huge. They forget how to walk, right? And then if they're bedridden, they can get bed sores or decubitus ulcers, right? You got to turn the patient every 4 hours, right? If somebody's laying on their back for too long, they're going to get sores, especially in the sacral area right here, because there's like barely any flesh there. It's like bone and like basically a little bit of tissue. And they can get sacral ulcers. They can get sepsis from that and die. So that happens. Like if you see neglect in group homes or like long-term adult care facilities, and they see like, that's neglect. There's been lawsuits over stuff like that, where they're not turning the patient over as much as they should. And then dehydration or malnutrition. They don't remember that they need to eat or drink. So those are all very common reasons why a person might pass away with advanced stage Alzheimer's. Again, here are your 5 A's: anomia, amnesia, praxia, agnosia, aphasia. Again, neurofibrillary tangles, beta amyloid plaques. Those are going to be the 2 major hallmarks. Cortical atrophy. Again, you can see widening of the ventricles. Everything else is just completely atrophied. If you did an image, a CT scan, you would see that most of this area over here would be all taken up by CSF, right? Just like all the other neurodegenerative diseases that we looked at. So here's a grade 1, right? So normal brain versus advanced stage dementia. What the heck? This is a PET scan showing cortical activity. Normal individual, the brain lights up, right? Whereas with Alzheimer's, you're going to see reduction in activity in those cortical regions. And these studies are done by looking at glucose uptake. Right? The brain consumes glucose. That's the primary source of energy. And so whenever the brain is using a lot of energy to be activated, you're going to see a lot of glucose uptake. Whereas if you see diminished glucose uptake, that's what you're going to see with dementia. There are vaccines in development. So here's an article from 2018. Then I put in an article from 2023 that was talking about the advancements of this. They were doing these vaccinations in rodent models. My colleague, Dr. Jackson, shared this one with me over here. This is another update on the Alzheimer's vaccine. So the FDA fast-tracked an immunotherapeutic vaccine for Alzheimer's. And so right now they're completing phase 1. They're going into phase 2. So super, super cool. If we can develop a vaccine that can help basically stave off the accumulation of beta amyloid and neurofibrillary tangles, that would be a huge game changer. Help to reduce Alzheimer's, which affects a lot of people. Show of hands, how many people know somebody personally in their life who has been diagnosed with Alzheimer's? The majority of you guys. Absolutely. I mean, I grew up in an older town. Like was kind of like a retirement community, so like tons of my neighbors were like Alzheimer's, dementia, right? Interesting people too. Like the guy that lived across the street from me, he was a World War II bomber, right? So he was like in those bomber planes. And so he had crazy stories from World War II. Super cool stuff. And then he developed Alzheimer's, him and his wife. So super sad. All right, now let's switch gears from Alzheimer's. Let's talk about Lewy body dementia. What is the Lewy body dementia? What is it a combination of? I told you guys last week. It's a combination of 2 diseases. Yes, good. Lewy body dementia is Parkinson's and Alzheimer's. I used to think that Robin Williams killed himself because of his bipolar. And I think a lot of people thought the same thing too. Because that is actually a huge risk factor in bipolar patients. Bipolar patients, especially when they're in that depressive phase, after they go from like mania, they'll go into a deep depression. They're very, very, very vulnerable to suicide during that depressive phase. So that's what I thought happened to him. But no, he actually was misdiagnosed. He had Lewy body dementia. So horrible stuff. This is an article that was written by his wife. This was published in 2016. It's actually published in the medical journal. Robin was losing his mind and he was aware of it. Robin was growing weary. The Parkinsonian mask was ever present and his voice was weakened. His left hand tremor was continuous now and he had a slow shuffling gait. He hated that he could not find the words he wanted in conversations. He would thrash at night and still had terrible insomnia. At times, he would find himself stuck in a frozen stance, unable to move and frustrated when he came out of it. He was beginning to have trouble with visual and spatial abilities in the way of judging distance and depth. His loss of basic reasoning just added to his growing confusion. So if you want to read a really heartbreaking article, this article it's tragic. It's absolutely tragic. So Lewy body dementia is a really, really horrible condition. Super sad. And again, it's like the worst of both worlds. It's Alzheimer's and Parkinson's. So you get alpha-synuclein accumulation. By the way, make sure you know alpha-synuclein is one of the hallmarks of Parkinson's. Okay, alpha-synuclein, also misfolded protein. So you get alpha-synuclein accumulation, which basically destroys dopaminergic cells, and acetylcholine. So if you don't have dopamine, you get Parkinsonism. If you don't have acetylcholine, you get Alzheimer's. So it's a combination of both. Other things that you see with Lewy body dementia, you see visual hallucinations. So not only are you getting all this stuff happening, but on top of that, you're getting visual hallucinations as well. So terrible stuff. It is a pretty major cause of dementia, right? 10 to 20% of all cases will be Lewy body. It affects older individuals, just like a lot of the other ones. Right? Men, unlike Alzheimer's, are going to be mostly affected by this. History of head injury could be a risk factor. Here's the chief complaint, and this is going to be from a person in their family or in their life. They're going to say, they're not the same person that they used to be. So you're seeing personality changes, complete personality change. So really sad stuff.
It happened little by little. First, he would forget things, and then he'd lose track of what he was doing. Lewy body dementia took over the life of the man you're about to meet. The disease is the second most common form of dementia, Alzheimer's being the first. There is no cure, but experts at Mayo Clinic are researching Lewy body disease in hopes of improving the lives of people who struggle with it.
In hindsight, though, there were things going on before, but you think, I'm thinking he's 75, I'll be there one day. It's just part of the aging.
But the little changes Marjorie Zellers noticed in her husband Richard were early signs of Lewy body dementia.
Expressions were almost not there anymore.
Richard also developed Parkinsonism, which often accompanies a diagnosis of Lewy body dementia.
And the stiffness in walking, his gait changed tremendously.
Their lives have also changed tremendously.
Because he was a boater, tennis player, racquetball player.
Richard is not independent anymore. His symptoms are slowly getting worse.
6 months ago, I just kept thinking it's going to go back. I kept wanting it to be like it was. But it's taken a long time to realize that it's not.
In a moment of clarity, Richard describes what it's like to slowly lose function.
It's like we wrote all your information on a blackboard and just come in with an eraser and just zap through it. And what's left is the problem. And the other ones are gone and then going to come back. You can try and improve on it.
And improving on it is what Dr. Tanis Furman and Dr. Dennis Dixon strive to do.
We try very hard to detect and diagnose as early as possible because our goal is to try to reduce patient suffering and improve their quality of life. And if we can increase the person's level of functioning to a higher level early on, that's an appropriate goal for us.
Dr. Furman says it's key to make sure the diagnosis is correct. You see, Lewy body disease is often misdiagnosed as Alzheimer's disease, and the two may respond differently to some medications. And because there is no cure, the disease will inevitably progress. Dr. Dixon is researching what Lewy body disease does to the brain.
So the idea is to find molecular underpinnings of the disorders that can be used for biomarkers to diagnose it accurately. And also, if we study the molecular and pathologic underpinnings of the disorder, those might lead to avenues for treatment.
The hope of new treatments to improve the lives of people like Richard Zellers.
In addition to making sure the diagnosis is accurate so people can get on proper medications,
Dr. Furman says it's also important to help patients and their caregivers get the support they need at home. That can ensure a better quality of life for patients and their loved ones. For Medical Edge, I'm Vivian Williams.
So again, behavior changes, visual hallucinations, impaired judgment, impaired thinking, Parkinsonism, right? All the stuff you see in Parkinson's, the stiffness, the mask face, all that. Pill rolling in the fingers. Also autonomic dysfunction, so like incontinence, for example, dementia, right? Family history, you might see family history in here. So you can also do MRI, right? You want to be able to rule out other things. Could be, you want to rule out things like tumors and whatnot, right? Things that might be other causes of cognitive decline. There again is no cure, but you can give them acetylcholinesterase inhibitors to help with the acetylcholine, and you can treat the Parkinsonism with gold standard treatment, levodopa, carbidopa. But at some point, they're eventually going to pass away from the condition. So
why, in Alzheimer's disease, many of your brain cells or neurons die. In Lewy body disease, some neurons die, but many are still alive. They're just not working properly. Certain medications called cholinesterase inhibitors help trigger nerve impulses from one brain cell to the next.
Cool. So decent treatment, but again, it's not curative. Acetylcholinesterase inhibitors just basically help to improve the symptoms. That's it. That's it. Any questions on memory and cognition? Let's log in. Let's do a couple questions here on quizzes, and then we'll do a comprehensive final exam review, so I can tell you which topics to focus on. All right, so go ahead and log in. Again, make sure you do these questions, the quizzes questions. I literally pull up the quizzes questions when I'm writing the exam, and I'm like, oh, that's a good topic. I'll use that topic to write this exam question. So make sure you go over those as like a study tool. Consider that your study guide, basically. All right. Okay, good. So, Lewy body dementia. We literally just talked about that. So, acetylcholine and dopamine is going to be the major thing underlying Lewy body dementia. Let's do a couple more. All right, good. So know your different types of memory, declarative and non-declarative memories, right? So non-declarative memories would be things that, for example, are skills, right? So learning how to ride a bicycle, right? That would be an example of like non-declarative memory. Declarative memory can be like episodic memory, right? Where you remember like episodes within your life. Like, what did you have for breakfast yesterday? I don't know, an omelet or something like that. So things like that would be falling under declarative memory. Okay, let's do one more, and then we'll do the final exam review. The little graphs, are they too tiny? Oh, you're looking on your phone, right? What about on your laptop? Does it work better? Or no? We'll go over it together. All right, so the correct answer on this was E. So the study had to do with basically depriving a group of food, right? So they were fasting for 12 hours. And then the other group was fine, like they didn't have to get any food deprivation. So group B was the one that was fasting. Whenever they saw a food-related item, right, they would have a much better memory of that item, basically, right, compared to the other groups. The other groups, you know, they were fed, they didn't weren't really paying attention as much as the people who were like starving. 12 hours of food deprivation, I guess, can make people go crazy. All right, so that is basically it. Please do the rest of those questions on your own time. Oh, well, it's been a blast of a semester. I really enjoyed working with you guys. And thank you also for your patience and working with me as I develop this class. So
I know, it's so sweet.
This is a very fun class.
I appreciate that.
Yeah, I had people asking me about neuro, and I always were good words. So
Appreciate that. Thank you.